What I want to talk about is really not the whole broad topic of calcitriol induced hypercalcemia, but a few patients that have got me interested in this condition, which were relatively recently discovered, causing CYP24A1 mutations. So I'll briefly talk about causes of calcitriol induced hypercalcemia and focus on what's been called idiopathic infantile hypercalcemia, although obviously it's not just infantile or I wouldn't be talking about it. So for those that aren't endocrinologists, just to refresh your memories, if there's a hypocalcemic stimulus, the parathyroid glands via the calcium sensing receptor will make PTH, which will protect the serum calcium by increasing bone resorption, increasing calcium reabsorption at the renal tubule, and increasing production of the active form of vitamin D125. Conversely, if you're hypercalcemic, you should lower PTH, and assuming there's no other stimulus to 125D production, such as low phosphorus, the 125D should be lowish, or at least normal. So we divide hypercalcemia into PTH dependent, where the PTH is higher and appropriate, the parathyroid disorders, and PTH independent, and I'm going to focus only on this top line, calcitriol mediated, which typically is granulomatous, inflammatory, or malignant. And in these diseases, the 125 level is high or inappropriate. And I want to make one point because I've seen even endocrinologists not recognize that a 125D does not have to be frankly elevated. It just has to be inappropriate. So if you have somebody with no PTH or no PTHRP and a normal phosphorus, and the 125D is, and the calcium's high, and the 125D is 50, that's inappropriate, and that's compatible with calcitriol induced hypercalcemia. So let's start with a patient. This woman is 27, she's pregnant, and she's got severe hypercalcemia in the 14s. Now, she had a pregnancy 7 years earlier. There was a calcium 1 month postpartum when she presented with a kidney stone, which was 13.8, and a PTH was suppressed. And then she had 2 other calcium levels between the 2 pregnancies, which were normal in the 9s. No unusual ingestions. Everything else was really kind of non-contributory, and her exam was normal. Now, she came to me completely worked up, really. Her PTH was suppressed, her 25D was normal. She had an SPEP, which was normal, a phosphorus and creatinine, which was normal. She was markedly hypercalciuric, PTHRP undetectable, and the 125D level very high. And they did ACE, ANCA, cortisol, chest x-ray, MR imaging, and found nothing. So if we think about what are the things that cause calcitriol-mediated hypercalcemia, this is actually a study from Australia where they looked at roughly 100 patients. And as we would all expect, sarcoid was responsible for half of them. And the next big group was hematologic malignancies, typically lymphoma, with a smattering of other much less common things, infections and other cancers and so forth. Now, this is a list that I usually keep of all the things that I found that have been reported with this. And obviously, I'm not going to go through this. I just keep this list. But there's just an update paper just published on rare causes of hypercalcemia. And in that, there's another list of things, some of which are conditions which I've never even heard of that have been associated with calcitriol induced. So, I mean, if you really get into trouble with a patient, you need to look at these lists because it's just a lot. So let's move on. Well, she didn't have a response to prednisone. That goes against granulomatous or inflammatory. No evidence of lymphoma. And I didn't have this information until much later, but I'll give it to you now. Her parents had normal calcium. 2 sisters had normal calcium. 1 brother had a calcium of 10.8 with a low PTH. And I don't have any other data on him. And so this makes us think of this idiopathic infantile hypercalcemia. And let me dispense with type 2 first. Type 2 is really a phosphate transporter where they have mutations in the phosphate transporter, renal phos loss. That causes a high 125D, and the high 125D causes hypercalciuria, hypercalcemia, and a low PTH. But what we're really talking about is type 1, which was first described by Schlingmann in 2011 in the New England Journal of Medicine. And this is mutations of the 24-hydroxylase. And this 24-hydroxylase takes 25D to 24-25D, and also 24-hydroxylates 125D to start the deactivation process of 125D. And the things that stimulate 1-hydroxylase, like PTH, and inhibit it, like 125D and FGF23, are just the opposite. So this is an enzyme system that his goal is to keep 125 in balance. Now, remember that the hypercalcemia is presumably caused by increased absorption of calcium, but also by increased bone resorption. 125D at high levels is a bone resorptive hormone. So, additional information. Her 24-25D was non-detectable. She had 2 pathologic variants of CYP24A1. We can't tell from this study if they're on the same, from one parent or from one from each parent. I think the assumption is it's more likely she's a compound heterozygote. She was managed with hydration. Her calcium came down a bit initially postpartum, but then went right back up during lactation, as high as 13s. And finally, when we convinced her to stop nursing, it normalized. The PTH went to the low end of normal, 125 a little high, but our urinary calcium remained pretty high at 400. So let me go on to one of our other cases. This is a patient who we just recently evaluated. 55, stones back to his 20s. Mild hypercalcemia noted in the 1990s. He has hypercalciuria and a strong family history of kidney stones. So I was able to get this old laboratory data on him, and you can see him in the 90s. He has this kind of mild hypercalcemia, and he had 1 N-terminal PTH, which was undetectable. Now, I then don't have any data between 2011 and 2019, but over the past couple of years, his calciums are 10 to 12, ionized is elevated. Interestingly, the first PTH we got was 30, but subsequent ones were lower. This is at the low end of our normal range. And we actually, he's not on biotin, and we studies for heterophile antibodies, and we actually did PTH on a different platform. His phosphate levels were normal, SPEP, PTHRP were normal, ALK-Phos normal, but his 125 was really high, 226, and urinary calcium 790. So my first question was, is this PTH dependent, or is this 125D mediated? Now, Rob will think for a second, is this the patient that I sent him a question about? It's a different patient that has a very similar story. Well, I thought this seemed more 125 mediated, and he turned out to have a pathologic variant of CYP24A1, as well as a variant of unknown significance at another place. And again, you can't tell if they're cis or trans. And even more interestingly, he has a known disease-causing pathogenic variant of the ALK-Phos gene. His ALK-Phos is 88, and nothing in him made me think of hypophosphatasia. This was done because they do a wide genetic kidney stone panel, and that included the ALK-Phos mutation. This is a summary of the 4 patients we've seen. So patient 1, she had no response to prednisone, marked hypercalcemia during pregnancy and lactation, and then normalized after pregnancy and lactation with low PTH and hypercalciuria. Patient 2 was interesting because she was also a young woman, but the striking thing about her was her calcium would go from 10 to 13 with no apparent reason. And not surprisingly, her creatinine would go up. Creatinine would go up to 1.5 when her calcium went up. And she was a nurse. She was doing everything we think properly. And she also was a homozygous for a pathogenic variant. Case 3 was kind of like case 1 in that she was hypercalcemic during pregnancy and lactation, and was a homozygous for a pathogenic variant. And case 4 is this man who presents with stones and hypercalcemia for years and years and years. So these mutations are known to cause infantile hypercalcemia, and now several reports of adult recognized hypercalcemia, and just people with hypercalciuria and stones. Most are homozygotes or compound heterozygotes, although there have been reports of what appears to be dominant inheritance, not surprisingly worsened by giving patients vitamin D, which gives too much substrate. And what's been reported, like our patients, is significant worsening of hypercalcemia during pregnancy. I think our cases extend this to lactation as well. And that hypercalcemia can be really labile and be very severe. So how about this, the heterozygote thing? So this is an interesting paper that was just published. It's a large family with one truly affected member. And what they did was do genetic profiling and some biochemistry on family members. And what they found was that the calciums in the heterozygotes were slightly higher. The 25Ds in the heterozygotes were slightly higher, but there really wasn't much else that was different between the wild type and the heterozygotes. Now, they didn't do urinary calcium, and I suspect that's the thing that's most likely to be different between the heterozygotes and the wild type. And now this is a study trying to look at whether you can distinguish this from other causes of vitamin D mediated hypercalcemia. And this is actually from Rob's colleagues, include, I don't know if Peter is on, but Peter Tebben is one of the authors of this paper. And they looked at a handful of patients who had this mutation and compared them to people, for example, with lymphoma and sarcoidosis. And the only real differences were young age at onset. These were on average much younger than the sarcoid and the lymphoma. Family history, kidney stones, and nephrocalcinosis being present. Now, there's one other interesting thing. This is the lowest PTH level. And I found it interesting that the lowest PTH level in some of these patients is not fully suppressed, which is kind of interesting. I don't know why that is, but I think it's interesting. So the diagnosis, low 24-25D, although it can be detectable. A lot of people do this ratio. This is what they do at the Mayo. And they say it should be more than 50 in the homozygotes, but there's overlap. And it can be, they have a disclaimer, it can be less than 25 in heterozygotes. It's not inexpensive. And in my opinion, if you really have a high index of suspicion, molecular testing is probably worth doing. Hold on. So treatment, hydration. These people should restrict calcium and vitamin D, use sunscreen if they're out in the sun. Ketoconazole, fluconazole, and rifampin have been used because they can interfere with the enzymes that make 125D. And I think most of the reports are with this. Not with this disorder, but with other 125D producing disorders. There is a report with cinacalcet use, and this is from Rob, actually. And I think the belief is that the calcium sensor in the gut is affected, and that causes decreased calcium absorption. But after I finish, I'll let Rob comment on that, because this might be something worth trying. So questions, why the hypercalcemia during pregnancy? I suspect this is 125D production by the placenta. Why the hypercalcemia during lactation? Well, during lactation, you do get intermittent PTHRP production. Now, in our patient, it was normal, but I'm not sure. I think you'd have to time it to get it right. So I think this might be the cause. Why is the PTH not more suppressed in patient 4? And in one of the cases, at least, from the Mayo Clinic? I'm not sure. Now, I did find a report of coexistent primary hyperparathyroidism and this disease in a patient who also had CKD. And does the ALK-Phos mutation in patient 4 modify the effects of this? Some of these patients are hypercalciuric and even hypercalcemic. And so I'll just summarize. Calcitriol associated hypercalcemia, the 125D is high or typically high normal. Most common is sarcoid and lymphoma. There's a long list of other disorders, and you can look at these lists that are published to help you if you have a difficult case. They're often granulomatous. I think primarily treat the underlying condition, and the hypercalcemia is often steroid responsive. The CYP24A1 mutations should be considered as an unexplained calcitriol induced hypercalcemia. They're more likely if it's young onset, family history, or if there's a long history of stones or nephrocalcinosis. Diagnosis is typically with this ratio of 25 to 24-25 and molecular testing. And I already mentioned the treatment, and we can ask Rob to talk about cinacalcet after. And with that, I'll end, and I think keep us on time. Rob, do you want to comment on the cinacalcet?
Well, yeah, I mean, I'll say two things. One, we've characterized a family as well with CYP24A1s with biallelic and monoallelic mutations, and I think there's a definite gene dose effect based on that data. So there may be a lot of people out there with a single allele who have mild intermittent hypercalcemia, hypercalciuria that we just don't know about. As far as the cinacalcet goes, I think I'll just say that we've used it in a patient with this mutation. We've used it in a patient we think has an NAPI2C, and then we use it in another patient with 125D where we can't really figure out why they have it. And it works in lowering the calcium. Whether it's the right thing to do long term, I don't know. We measured 24-hour urines, and I don't think it's a gut thing. And we think we have some hypothesis on what could be going on, but I don't think we really know yet. So I guess if your back's up against the wall and you're desperate, I think using cinacalcet might be reasonable, but we haven't published this data, so.
Okay. There's a message from the group. For us non-endocrinologists, why does lactation exacerbate the high calcium in these ladies?
Well, my theory is that it's PTHRP, but I'll ask anybody else to comment on that. Rob, do you have any ideas?
Yeah, I think so too. I think PTHRP combined with 125D.
All right, we do have time for more questions. So if you want, one just came in. How can this be safely treated in pregnancy if hydration and no supplements is not good enough? What is a safe calcium level in pregnancy when much higher than normal?
I don't know the answer. I certainly wasn't going to use, at the time, ketoconazole was the drug that had been reported when I saw this first patient, and I certainly wasn't going to use ketoconazole. You know, I don't really know what you can do. Somebody, you know, they tried high dose steroids, that did nothing. Every time she got really sick, she went in the hospital. They gave her a lot of fluids, and it came down. And I didn't give her any drugs, and I don't know if there's any real safe way to do it. The important thing in a patient like this is to watch for hypocalcemia in the baby who may have his parathyroid suppressed. I don't know. Does anyone else have any thoughts of how you could treat this patient in pregnancy?
I agree. I think just fluids. I mean,
yeah, I don't know what else you can do.
To be honest, when we have these patients, ketoconazole is a hard drug to take, so I've never succeeded with that. And we just tell them to avoid the sun, drink plenty of water, but they do get these wild swings in calcium. I've never understood, you know. And I don't think it's just sun exposure. I don't know whether there's something else going on.
Yeah, I don't think it's just sun exposure either, because it wouldn't be like the vitamin D was markedly different.
Yeah.
All of a sudden their calcium would be way higher, and you know, it wasn't like any precipitating event that I could figure, but you know,